Come va gestita l'eventuale interruzione della terapia col denosumab, un farmaco molto importante per la cura delle forme più severe di osteoporosi? Noi ne abbiamo parlato con la dottoressa Elena Tsourdi, che abbiamo incontrato qui a Bari al 22esimo congresso nazionale della Siommms.
Dr. Tsourdi, why we are speaking regarding denosumab discontinuation? Why there is this issue?
Yes, the recent years an issue has arisen with denosumab discontinuation because it has been shown that if you stop it abruptly, there is an increased risk of fractures, especially for vertebral fractures. So we know that after denosumab discontinuation, the bone which was gained is getting lost very quickly, very rapidly. There is an uprise of bone turnover, and this translates into an increased risk of fractures.
The ECTS guidelines are trying to help the clinician to manage this topic. First of all, when to start denosumab according to these ECTS guidelines?
So the subject of when to start denosumab has now been re-evaluated after we know of this clinical problem. So I think one should be quite careful if one considers to start at very young patients. This maybe should be an issue that we cannot recommend anymore. Or if we start in patients that are not in very high risk of osteoporosis. So this would be two situations where I would be a bit reluctant to start already with denosumab, because we know that then we will have this problem of how to manage its discontinuation.
The second point is the decision regarding when to stop denosumab. And it is mandatory to stop denosumab at one point or another, or you could continue for how long you decide? Because, for example, there are clinical studies for more than 10 years of continuous use of the drug. So the decision of when to stop is based upon which kind of considerations?
Yes. So first of all, it is not mandatory to stop denosumab. You mentioned the 10-year data. These are the longest data that are available until now, and they show good efficacy and also good tolerability of denosumab. But in clinical practice, we have patients that are also on denosumab for a longer time as this. So clear message should be it is not mandatory to stop it. But there are some situations when one should think, what would happen if we give denosumab for the lifetime of a patient? And there are some hypothetical risks, as for example, the situation of frozen bone, which could then mean that bone turnover is completely suppressed, and then you have a higher risk for atypical femur fractures. Or another risk, which is being somehow linked with a very long term of denosumab treatment, is the risk of osteonecrosis of the jaw. So this would be maybe the two clinical considerations to think about stopping it. But clear message, it should be not stopped without having a follow-up treatment.
And so the third point, probably the most important one, which drug to use after denosumab stopping?
So the best data have been with bisphosphonates, and mostly with intravenous bisphosphonates. There are some data with selective estrogen receptor modulators, the Siommms, but these show that you cannot really salvage all the bone loss that would happen after denosumab discontinuation, so it's not recommended. One clinical point which is also important is that you modify also the choice of drug and the duration of the follow-up treatment. You modify this according to the previous duration of treatment with denosumab. So if you have patients that have a short duration of denosumab treatment, for example, up to 2.5 years, then you can consider oral bisphosphonates, maybe for 2 years. If you have patients that have been long-term denosumab patients, then only one zoledronic acid infusion will not be enough. These are the patients where you have to follow up, do a second round of IV zoledronate, and then to have them in very constant care, measure the bone turnover markers, estimate their fracture risks, and see if you have to treat them also beyond this. But most data now show that you need at least 2 infusions of zoledronate in order to be able to somehow counteract this overshoot of bone turnover which happens after stopping denosumab.
And after these first 2 shots of zoledronic acid, it could be a good choice to continue with oral biphosphonate, or is enough the zoledronic?
Yes, so the new guidelines seem to suggest that if you have a BMD threshold that you have reached under these 2 shots of zoledronate, and this is the suggestion that it could be a T-score of minus 1.5 or better at the hip, then it would be enough then to stop them with their treatment. But then you have, as I say, to follow them up and do bone turnover markers and also bone mineral density in future time points to see if their situation changes.
And finally, denosumab remains a good drug, also considering this attention that you have to put on the discontinuation issue.
For sure, and I mean there are also other benefits to denosumab. For example, it can be given in patients with renal insufficiency. This is a category, of course, of patients that you cannot give intravenous zoledronate, especially if they have a GFR which is lower than 30. And one has to say that given like the magnitude of bone gain that you have in this 10-year data, of denosumab, it continues to be a highly potent and effective drug.